Hi guys, this is Alicia with Good Morning Sunshine. So today is Wednesday, I believe, and we've had lectures today, and then I have a lab later today, but I'm going to go over a few lectures with you. We had Parasitology this morning and also pathology, I believe, clinical pathology. So I'm going to start with Parasitology. We're in the order of the Strongylida. We're going over strong isles today and the rest actually today. So the hookworms as well as the meadow strongyles. So starting with the superfamily of Strongyloidea. So that's most important in horses. Their general characteristics are they're mostly parasites of the gastrointestinal tract. They generally have a large buccal capsule, which means basically their mouth cavity. And they're plug feeders. They usually size up to about 15 centimeters. Yeah, and here's what they look like. So within this family of the Strongylidae, they have subfamilies. They have the small strongyles and the large strongyles. They have unique names to them. So they have the Cyathostome and the Strongylinae. So the Strongylinae are the large and the Cyathostome are the small ones. The small ones are up to about 2 centimeters and then the large ones are up to 5 centimeters. However, it doesn't matter the size. The large ones could be small as well, but we'll get into the differentials of what the difference is between the two subfamilies. So for the small strongyles, there are about 50 similar species. They cannot tell eggs or immature stages apart. This group, again, is known as the Cyastominus. So again, they have their own lifestyle. So in the L2 stage, it's kind of like the other ones I talked about in my other lecture on parasitology. Well, not lecture, because I'm not lecturing you, but I am telling you stuff. But the L2, they can't eat, so they need to find a host very soon. L3 is the infectious stage, and they are in the large intestines, and they molt to L4 here. So basically here is the life cycle. I'm going to show you here. So the eggs, so again, the eggs in the feces develop into the L1, L2, and then L3 stage larvae. And then the L3 larvae get themselves onto the grass, and then the horse eats the grass and ingests the L3 stage of the larvae, which then the L3 larvae enter the large intestinal mucosa, and then the L4 larvae develop into adults and lay eggs. So that's basically the life cycle of it. So again, following infection of these, the larvae go into the large intestines. They enter crypts of Libercon and they penetrate the mucosa for a period of the larval development. They return to the lumen to mature. The minimum prepatent period for these are about 2 to 3 months. The larvae in the wall may become hypobiotic. They can do this for as long as 2 years, actually. So that, remember, hypobiotic means they stay dormant. They just stay there. They don't go to the mature stage quite yet. They have a dynamic relationship as adults are lost from the lumen. The new larvae move in and maintain population of adults. The seasonal effects on arrest also seen, and then the L3 can undergo, like I said, hypobiosis. So again, continuing here, so here's what they can do. So again, L3 being the infection stage. But so the eggs and the feces, they go through the L1, L2, hit the infectious stages of L3. They are orally ingested. The L3 is then in the mucosa. They can become the L4 in the mucosa and L4 in the lumen to become L5s, to become adult worms in the cecum and colon. Or from the L3 stage in the mucosa, they can become encysted larvae. So L3 and L4 here. They have synchronous emergence. So this is where they lie dormant before they go to the L-form in the lumen and later, and then mature that way. So these small strongyles are not highly pathogenic parasites. They are low to moderate numbers in healthy horses. There's no apparent effect. Their clinical importance is most pathogenic stage is larvae. So we have to remember that. and then as emerged from the intestinal wall will cause inflammation. Sorry, I'm just highlighting that because I remember I need to memorize that. So more larvae activating equals a more serious disease. The equine can deal with small amounts in their small intestines, but the young equine cannot. So again, they have two clinical diseases. They have chronic sciatostominosis, which is with the continuous lifestyle that I was talking about, or they have the acute larval sciatostominosis. God, these are big words. Which includes when they lie dormant with the hypobiosis. So the chronic is the gradual inflammation and thickening of the gut wall. It's possible protein losing to enteropathy, and then the clinical signs may include intermittent diarrhea, mild to moderate colic, poor condition, and hypoproteinemia. But for the acute larval disease, it has a rapid onset. It occurs when large numbers of arrested larvae synchronously emerge. So again, when I said they lie dormant, remember, they all come into the same life cycle when they're maturing, when they wake up. So that's what it means by the synchronous emerging of them. Clinical signs are like fever, diarrhea, which leads to dehydration, edema, which leads to hypoproteinemia, drug treatment of horses with high worm burden, and then seasonal. This usually occurs in the late winter or early spring because the larvae are reactivating at the same time. The diagnosis for chronic sciatostominosis is the large number of strong out eggs and feces is supportive of this, but for acute, it may not be many eggs in the manure at all. Typical for strongylid nematodes, most normal adults can control worm populations, so the immunity is 3 to 4 years are the most susceptible to this parasite. Now getting into the long strongyles, the only important one is the strongest vulgaris. So its life cycle, the adults are in the large intestine again, they're 3 to 5 centimeters. They have a complex larval migration. So following infection, they molt. L4 migrates through the arteries. It reaches junction of the cranial mesenteric artery and aorta. They return to the large intestines about 4 months after infection. So occasionally larvae migrate to other locations. But the infectious stage is the L3 stage. The pre-patent period for this guy is 6 months. So the Strongylus vulgaris pathogenesis, it causes verminous arteritis and aneurysm. The larvae damage arterial vessels, leading to thrombus formation, which thrombus can reduce blood flow. Portions of the thrombus may break off actually, which is known as embolus, which block blood flow distally, and then would cause ischemia. In severe cases, necrosis of portions of bowel occur, lesions regresses after worm leaves or treatment occurs. The clinical signs for these long strongyles, so Strongylus vulgaris, are colic, so thromboembolic colic, but he also said that this isn't important in horses anymore, so let's go with clinical signs being abdominal pain. In severe cases, it causes death. The diagnosis is actually difficult because you can't differentiate the eggs or there's no eggs at all. The clinical disease is much less common since development of the larvicidal drugs in the 1980s. So that's why we don't see much of this anymore. And now we're going to get into hookworms. Also known, the superfamily is Ancylostomatoidea. But also known as hookworms. We're going to talk about these in dogs and cats, and they are blood feeders. So we have canine hookworms. We have the Inclinostoma caninum, which is the most important in our region, and then we have the Ancylostoma brasiliensis, which is in southeast coastal U.S. and South America, and then we have Ucinaria stenocephala, which is the cold climate hookworm. But here's what they look like. So those are our hookworms. But the canine life cycle one, the external is the same development from egg to L3, so the same I've been talking about. It's best in moist and shaded and slightly sandy soil. The dogs infected are from environment by the ingestion of L3. Some can ingest through the paratinic host, like a rat. And this patent period is 2 weeks, but they can also skin penetrate by L3. So this is the most important, actually. The L2 is the same. It's a cuticle and can't eat, so they need to find a host. But yeah, they can do this by skin penetration or the ingestion of L3. So following skin penetration, if we go that route, larvae can migrate to the heart and lungs and then either be coughed up, swallowed, and become developed into the small intestine. This happens, and it takes about 3 to 4 weeks for this. Or they can travel to tissues and become dormant. This is called somatic reservoir larvae. So in mussels, they can wake up when the animal becomes pregnant. So that takes about 40 days because they want to go, get into the puppy. So they're still in the L3 stage here, though. The puppy's pre-pain period is also 2 weeks. If they don't want to be awakened at pregnancy, these parasites don't want to wake up, they can have a larval leak instead and go to the small intestine. This pre-pain period is about 3 to 4 weeks, but only very few parasites do this as well. So again, a single infection of a female dog can result in the infection of more than once per litter. After treatment of the adult population, arrested larvae can move into the intestine and replace adults that are removed. This is known as the larval leak that I was talking about. The eggs-laying worms in the intestine can come from, again, skin penetration, transmammary infection, ingestion of the L3, the larval leak, or the paratinic host, which I talked about with the rat. So they have many different life cycles they can take in this, which makes it very confusing. But here's a table basically showing all the routes they can take that I talked about. So the pathogenesis of this, the low worm numbers are asymptomatic. Young animals are very susceptible, however, also heavy exposure or the immunocompromised. Hookworms, again, are bloodsuckers and switch sucking sites at a few hours interval. They can have diarrhea, melena, and anemia and hypoproteinemia. They can also have skin lesions. And the immunity of this, they're like large animals, strongolids that we just talked about, and they develop following exposure. The diagnosis for this is a fecal exams. This is only common in the strongolid eggs. We can call them hookworm eggs. We are told to remember the pre-pain periods here, because in puppies, it's basically impossible to diagnose with a fecal test because there's no eggs. So prevalence in the 2009 National Shelter Survey. Nationally, there was 33%. In the Southeast, there was 53%. Much lower in dogs receiving monthly products. Those include the worm products that we give our dogs every month. And then we have the feline hookworm. So they're at lower prevalence than the Alisha-Good hookworm. So they're 8% in the National Shelter Survey, much lower in pet cats. It's not as pathogenic. It's little of any perinatal transmission, so no transmammary transmission. And then getting into the Cyclostoma brasiliensis, dogs and cats in the coastal southern U.S., the Caribbean, and Latin America. Not a very pathogenic hookworm in the definitive host. It's vigorous skin penetrator, so it's more important in public health. So getting into the hookworms and public health importance, it's zoonotic. Larvae can penetrate human skin. This is what we mean by zoonotic. However, we're not the reservoir, and we're not an intermediate host either. So we are the accidental host, which I've talked about in the first parasitology lecture. The larvae can penetrate human skin, like I said. In coastal and southern U.S., Caribbean, and Latin America, this is a problem. It produces serpiginous tracts, also known as cutaneous larvae migrans, which I'll show you a picture of here in a minute, and it's more frequently in people that deal with lots of soil contact. So this is what it looks like when it penetrates us humans, the feet at the bottom. And lastly, we have our last order of the Strongylida, which is the Metastrongylus. They have an indirect life cycle, so they don't produce eggs. They're long, slender adults in lungs and other tissue sites. usually have an intermediate host, such as an invertebrate, often a mollusk. It's usually diagnosed by finding larvae in the feces. Minor importance in domestic animals, with a few exceptions to be covered in later courses. So we really didn't get into it. He said it wasn't really important. So that was the end of the parasitology lecture. So now getting into clinical pathology, non-regenerative anemia. So first we went over a few definitions. So we have hypoplasia, which we've learned already, which is the less developed or never was there, so decreased in cells. We also have atrophy, which is the decrease in size and number of cells. And then we have decreased production, which is the both result in this. So we have bicytopenia, which means two cell lines. So the erythrocytes, meaning the red blood cells, the neutrophils, also known as the leukocytes, which are white blood cells, and the platelets. So any of these two things, so I gave you 3 examples, but if there's 2 cell lines, they have to be infected in this bicytopenia, so 2 of these have to be decreased. And then we have pancytopenia, which means that all 3 of those, the red blood cells, the white blood cells, also known as neutrophils, and the platelets, all have to be decreased. And then we have myelosuppression, which is the decreased production of platelets and red blood cells and neutrophils, also known as white blood cells. So you're suppressing one or all of these. And then we have myelotoxic and myelotoxin, which means something is damaging the precursing cells from above, such as radiation. And then we have the myelodysthesis, which means the marrow has been effaced or replaced, so the decreased reduction of most or all the cell types above. This could be from fibrosis or metastatic neoplasm or etc. So again, CBC, non-regenerative anemia, the criteria, you can't find evidence of any of these, so you can't find evidence of reticulocytosis or the evidence of acute hemorrhage or the evidence of hemolysis, so ghost cells and spherocytes. For marrow hypoplasia, you'll get decreased production. So selective erythroid hypoplasia means decreased red blood cell production when there is no bicytopenia or pancytopenia. But then we also have generalized marrow hypoplasia, which does have bicytopenia or pancytopenia. If there's no hemorrhage or hemolysis, then probably it's non-regenerative, but then you want to find out if it's selective or generalized non-regenerative anemia. So non-regenerative anemia, so we went over a few cases here. So I'm going to tell you about the one on the left first and then the one on the right. So this one here, there's a reduced red cell mass. The reticulocyte is in the reference interval. The plasma protein is okay, so there's no hemolysis here, no evidence of blood cell loss. So this is a non-regenerative anemia. The platelets are high. The white blood cell count is high. So this is a mild anemia. It's normocytic and normochromic. Then it's anemia chronic disease. So this is a select non-regenerative anemia on the left here. But on the right, the plasma is good. There's no hemolysis. There's plasma proteins aren't decreased. The white blood cells are decreased. And so are the platelets as well as the red blood cells. So we have normocytic, normochromic, non-regenerative anemia with pancytopenia. Because remember I said all those have to be decreased for it to be pancytopenia. And it's also generalized marrow process, because generalized means it includes pancytopenia or bicytopenia. So then we have nutrient disorders. So nutrients for erythropoiesis is iron, iron transfer proteins, erythropoietin, and thyroid hormones. So you can have selected erythroid hypoplasia here. Macrophages are where iron is stored. And then we have anemia of chronic disease and anemia of inflammatory disease. So iron's sequestration. So the iron is not available to the red blood cells. The hepcidin is negative regulatory of iron transport. The severity is mild to moderate. The red blood cell indices are normocytic and normochromic usually. The microcytic and normochromic is very rare, and the cause is almost any disease. So we have myelosuppressive agents and toxins. These interfere with the maturation sequences. So selective erythroid hypoplasia, red cells are repressed. This is when they take animal off the medication, get bone marrow samples to separate out the subtypes. And this is if you're normocytic and normochromic. That's when you would do a bone marrow test. But you can see on the CBC test, like a blood sample test, if you see decrease in red blood cells, but have normal neutrophils and platelets. The viruses of selectives are FELV, the drugs are RH-EPO, and it's idiopathic, it's autoantibodies, and it's immune-related process. And now getting into the generalized marrow hypoplasia, you would have to do a bone sample here. Viruses include FELV and the parvovirus. The bacteria is Ehrlichia. The drugs are chemotherapy, azathioprine, estrogen, trimethoprim, sulfamethoxazole, and methimazole. Its toxins are plants. It's idiopathic and autoantibodies. So then we got into myelopathosis, which means bad stuff in the bone marrow. It's a marrow replacement. It's generalized marrow hypoplasia. Myelitis can intervene. Leukemia can sometimes, but can be terminal. And myelofibrosis is often terminal. So we went over a few cases. We have case example 1. The singlement is a 5-year-old mixed breed dog. It has lethargy, inappetence, difficulty breathing. It's also depressed, fever, tachypnea, dyspnea, harsh lung sounds with crackles and wheezes. And in their thoracic radiograph, it shows pneumonia. So here was the blood test for this dog. So the red cell mass is reduced. It's moderate. It's regenerative. It's non-regenerative because we're looking at the reticulocytes. There's no reticulocytes, so it's non-regenerative. It's normocytic, normochromic. There's no evidence of hemorrhage, no evidence of hemolysis. So this is anemia with inflammatory conditions. In case number 2, we have a 3-year-old mixed breed dog. Visited with lethargy, vaginal discharge, attraction to male dogs, estrogen drug for 15 months for urinary incontinence, that being important. It's depressed, tachycardia, heart murmur, pale mucous membranes, vaginal discharge, and vulval swelling. So here's the blood work here. So the red cell mass is reduced, so severe anemia. This is there's no regeneration, so it's non-regenerative. There's no hemolysis. There's also no evidence of blood loss. The white blood cell counts are generalized. The neutrophils are low. The platelets are low. RBCs are low. So what did I tell you when I told you if all 3 of those are low? It means parasitopenia. It's also normocytic, normochromic. And here we are. So it was the estrogen drug that caused this non-regenerative anemia. And here he just gave us a chart so we understand here. But those were my 2 lectures from this morning. I'm about to get ready to study. I have most of my stuff down for tomorrow. I still have a lab later today too. And I have to watch our lectures still because I kind of came home early. But we just had one more lecture, so. And then I don't have lab until 4. I didn't realize that till late last night. But yeah. I hope you guys are having a good day. Fun time at work. Or if you're in school, fun time at school. I'll just be studying for the exam on Monday. So, I love you guys and thank you guys for watching.